Recorded on March 26, this discussion of the funding cuts at Samhsa could not be more timely. 1 hour after recording this discussion, the New York Times reported that the Trump administration is abruptly cutting billions from state health services.
When the HHS secretary gathers everybody and you have the CDC and HRSA, and if Samhsa wasn't at the table, behavioral health wouldn't come up. Yeah, HRSA's got some grants, CDC's got some grants, NIH has some grants, but they also have to deal with cancer, HIV, diabetes, right, everything.
Well,
and unfortunately, we still live in a day and age where with behavioral health, they get to it when they get to it. With Samhsa sitting at that table, they're saying, guys, don't forget. And so even every bit as important as the dollars is that seat at the table that's saying, the saying that the mental health community has, no health without mental health. You could say no health without behavioral health. But one of the largest public health problems we have in the United States should have its seat at the table.
Andrew D. Kessler, J.D., is founder and principal of Slingshot Solutions, LLC, a consulting firm that specializes in behavioral health policy. With 20 years of policy experience, over a decade in behavioral health, Kessler is a fixture in circles that advocate for substance abuse treatment, prevention, recovery, and research. He collaborates frequently with congressional offices, the White House Office of National Drug Control Policy, the National Institute on Drug Abuse, or NIDA, the Substance Abuse and Mental Health Services Administration, SAMHSA, and other federal actors. He is a frequent contributor to Politico, The Hill, and Alcohol and Drug Abuse Weekly. Kessler has written legislation and report language published by both the House and Senate, and is presented orally before such bodies as the Scientific Management Review Board, the College on Problems of Drug Dependence, and the National Conference on Addictive Disorders. He is a highly sought-after speaker on substance abuse policy and on advocacy training. As we'll see during the course of this interview, Andrew Kessler is not only a behavioral healthcare policy expert, but a leading voice for recovery in the nation's halls of power. Nikki Soda is an advocate and strategic marketer with a decade of behavioral health leadership who earned an MS in addiction policy from Georgetown University and the respect of peers nationwide. As executive director of Soda's Consulting, Nikki is helping treatment centers pursue public policy, organizational, and business goals. As director of membership and state advocacy for the National Association of Addiction Treatment Providers, NATAP, Nikki liaised with and advised industry leaders and developed extensive knowledge of the nation's treatment provider landscape through in-person visits and interviews. Nikki's experience gives her a profound understanding of the substance use disorder treatment landscape. Nikki brings a unique blend of treatment experience and strategic expertise to the field, having played a pivotal role in launching and scaling treatment programs nationwide. She has successfully developed and led alumni services, expanded referral networks, and guided treatment centers through admissions, marketing, and operational transitions. As co-president of the Treatment Professionals and Alumni Services, TPAS, she continues to shape best practices in long-term engagement and recovery support. With a proven track record in both front-end service delivery and back-end systems development, Nikki is recognized for her ability to turn ideas into actionable outcomes. Her deep knowledge of policy advocacy and patient care positions her as a trusted voice in the behavioral health space, always focused on ensuring that individuals receive the highest standard of support and care. So we're at a time when Samhsa is experiencing reduced funding. It is losing some of its funding, and in one way of looking at it, that opens a door to talking about maybe the broadest picture of behavioral health in the U.S. today, and where the field of behavioral health stands, where its underlying issues stand today, and maybe we can look at that through a lens that is a point of convergence between three primary factors. One would be the changes to the behavioral healthcare industry itself, mainly in the form of consolidation and commercialization, which is an ongoing theme that's been impacting the field and making change in the way that people access care and the type of care that is available. There is the need itself, the state of our behavioral health care in the United States. What's happening in the way of substance use disorder and mental health, and where are we today, and what progress has been made, but what challenges remain. And then third, in terms of today's policy and the philosophies of today's leadership, how might that shape things? So we kind of come together at this interesting convergence, maybe, of those 3 points. And at the head of it is, what we're seeing today with Samhsa having its funding reduced, and potentially, I think, according to some reporting at the time, that funding could be reduced by 50 to 70%, maybe more. I'm not sure. So, if it's okay, let me start out by asking, kind of looking through that lens. Nikki, if you would, you have talked about, and I think it's clear that within the field of behavioral health care, there has been an ongoing trend toward consolidation or commercialization, if you will, the rise of private equity and other equity-backed firms. Is that having an impact on the field? Is that still ongoing? And if so, what is that creating?
Yes. Well, so that's a great question. And without a doubt, mergers and acquisitions is a huge component that has very much shifted the landscape of what we see as substance use disorder treatment. And if you were to take a map and to look at privately owned treatment centers versus those that are now conglomerates or corporate owned or have been acquired by some type of large group, that map from just, let's say, 4 years ago, Kris, would be vastly different. The number of individually owned treatment centers has shrunk. I do not have the exact percentage of that. That's one of those things that's a little bit challenging to get. And unfortunately, there's not a database, although Samhsa does have one of the closest to being able to list. Their treatment locator lists over 30,000 substance use disorder treatment centers. But so going back to the mergers and acquisitions, it's absolutely had a huge impact. It impacts the quality of care. It impacts the access to treatment. And so with this shift, we've seen there's both pros and cons to it, but without a doubt, the number of privately owned and nonprofits has shrunk significantly.
Okay. What does it do in the way of approaches, if you will? Is there the consolidation of programs? Does that lead to the consolidation of programming? Our financial pressures, if shareholders, for example, and key stakeholders, of those entities, their needs have to be addressed, of course. If it's a financial concern, is that having impacts on the type of treatment delivered, on outcomes, the way outcomes are measured, perhaps?
For sure. Yes to all of those. So one example is there is a treatment center that had been established in the early 80s on the East Coast, and it was privately owned, and it was acquired by a large company a year and a half ago. And when this large company came in, they said, we are going to hold true to your policies and procedures, to your mission, to your values. Within 3 months, Kris, they were completely changed to the corporate group that came in. So all of their mission, their values, everything was changed to the corporate entity. So that's not saying that that's good or bad. It's just different. And so a lot of these corporates they have a blueprint for the quality of care that they're doing. So you are going to find the exact same. They have a treatment center in New York to a treatment center in Texas. No matter what the history of that center is, they're coming in with that. So there's some that are really good, and there's some that these corporations are coming in, and it is strictly how many admissions can we get in, does not matter. They are not vetting very well. And so there is that. So there's that pro and con component to it. Now, what I can say too is that there has been some privately owned treatment centers that have been acquired that are then able to get better resources to help revamp outdated facilities, that are able to provide better training to staff. And so for that access of care too, being able to maybe offer more scholarships because they have deeper pockets. So that's a definite positive. In regards to outcome, that's a very good question too, that I would love to be able to see once a merger and acquisition has taken place, if those outcomes are significantly impacted in a positive way. That would be good data to see.
Absolutely. And so I want to kind of roll that into the next question, but something that comes to mind. We know that individualized care and programming that can adapt to the needs of these conditions, which are incredibly complex, that addictive disorders, substance use, mental health disorders affect everyone differently, and some of the most effective approaches are ones that are very highly individualized. So this is it's not just particularly strong therapeutic alliances with individuals that are well adapted to understanding what an individual is experiencing, but particular types of treatments and the ability to assemble essentially a highly individualized care plan. And from what you're saying, part of that, it may or may not be at risk, but maybe it becomes more difficult as you begin to, consolidate and, sort of simplify, what becomes available, in terms of treatment, which is something to I think about for everyone there. The next one, and this is for both of you certainly, and feel free at any time to chime in. Certainly both of you. But it's the nature of the need itself, and when we talk about that, we're talking about substance use and mental health disorders. And just to kind of put this out there, it has been reported, which is a absolutely phenomenal and tremendous development, that the number of overdose deaths, in the United States is declining. It declined, I think, over the last two reporting periods. It's still astronomically high. It's something like 80 to 100,000 people who are losing their lives. The reasons for the decline are not totally clear, at this time. But what we also know on the ground, if we're talking with behavioral healthcare providers, both SUD, mental health, dual diagnosis, across the board, the need is significant. So we're seeing a tremendous amount of need for these services. Can you kind of speak to that? I mean, is that accurate? Is the need changing? Are we seeing fundamental shifts? It's still there, I guess, is what I'm trying to say. We shouldn't have a reason to take our foot off the gas at this point.
Yeah, I mean, absolutely. There's no reason to take our foot off the gas. Those of us who work in this space, especially in my area, which is on the policy side, I guess it's a universal constant. If it ain't broke, don't fix it. And if the investments we have made seem to be paying off, paying dividends, keep it up. The point you make about not really knowing why we've had this success is critical. And the reason is it points to the need for even more data. I personally am a data hound. Working in policy, data is very important. And there was a famous economist. It's one of my favorite quotes, and I always kick myself for not remembering the name of the economist who said it. But and I've seen the on a placard in more than one member of Congress's office. It says, "In God we trust. All others bring data." And it's true. And even as the overall numbers nationally have fallen from, let's say, at its peak, 114,000 overdoses in a 12-month period, because we don't study just a year. We study from the CDC in rolling 12-month periods. Where the latest information we've gotten is about 87,000, which on the one hand makes us so proud of the work we've done, and on the other hand continues to magnify the work that we need to do. Still far from an acceptable number, and still far from pre-pandemic numbers. I believe pre-pandemic we were at about 78,000. Also not acceptable. So we need this data, and it comes from several places. The CDC is one place. They have a home in the Injury Prevention Center at CDC on overdose prevention data, where they look at different pockets of overdose and what the trends are. But even though those national numbers come down, in different pockets of the country and among different demographics, it's not a constant. We are seeing increases in some areas, whether that be in certain populations based on their demographic, their socioeconomic, their race, their geography, needs to be studied, because we want to know why where it is coming down, what's working, and where it's not coming down or continuing to increase, what resources are they not getting? So it remains very much a challenge that needs to be unpacked. I want to add that when it comes to these, what if someone were to say best guess, what could be working? It could be availability of naloxone in certain areas. It's a very dark path to go down, but some economists have thought, is it a dwindling of the population who is susceptible to this? I don't know.
Yeah.
Is it the availability of fentanyl? Is it a supply issue? Which always leads me to think, what do the cartels have up their sleeve? Because if you think supply is decreasing strictly as a result of law enforcement, whether it's border, whether it's federal, local, state, they are doing the job they need to do, but never discount what the cartels have up their sleeve and possibly thinking, okay, we had a great run with fentanyl. What's next? Is it xylazine? Is it something we haven't heard of yet? Never discount the business acumen of the cartels. You had Nikki talking before in her spot about business, and, the cartels, let me tell you something, they know what they're doing. And this is not my area of expertise. I'm more of a clinical policy guy, but I like to keep up on the news. And whenever numbers tend to drop, that's usually a very, very good warning sign that the next big thing is coming. And that's why we can't always focus on just one drug. So all of these factors, is it supply? Is it naloxone? Overdose reversal? Is it harm reduction? We need to know these things so we can continue our best practices and, let's be honest, eliminate practices that may not be as effective.
Kris, I do want to add one more thing, and that was really good information, Andrew, that yes, the numbers have decreased on this last reporting, but isn't that all the more reason to keep pushing on the gas, to keep doing all the things that we're doing? So to me, it's mind-blowing that we're like, okay, the numbers are going down, so let's let off the gas now. That seems completely the opposite of what we should be doing. So to me, it's so surprising. Well, it's not so surprising. To me, we're doing the opposite of what needs to be done.
Yes. Yeah, absolutely. I mean, I might add in that, from folks I talk with in the field, it is all of what you just mentioned. It's also individuals showing up to treatment with higher acuity conditions, at deep levels of complexity. A lot of the social determinants of health, are driving a lot of
Kris,
this, Yeah, go ahead.
When you talk about complexity, the people I work with, we're seeing more polysubstance use than ever. And that's why the focus on one drug, so polysubstance use and the continuing evolution of the different opioids. Absolutely.
And I'm going to add one more thing: the complexity of the complexity of the patients that are admitting, but it's also really the dual diagnosis, because we're seeing so much more than just rarely is it ever just a substance use disorder, right? We're looking at trauma, we're looking at mental health issues. So there's significantly more dual diagnosis that are being admitted, and people are they're presenting sicker, and they're presenting later too. And so those are other key factors. And wait lists to get into treatment centers. But those, I just wanted to add that part. The mental health component is astounding right now.
Yeah, particularly among, I think, adolescents and young adults or emerging adults. This is also complicated, I think, in some ways by a previously unforeseen rise in cannabis use disorder. So, our friend Ben Court, is one individual among others who have recently written books that talk about, the results of commercial cannabis, on behavioral health. And that's very complex. Cannabis use disorder,
Absolutely,
in some ways, is more complex and takes more time than treating opioid use disorder because of the need to achieve stabilization, first. And a lot of the underlying co-occurring disorders that come along with cannabis use disorder.
Yeah, I'm glad you mentioned Ben Court, who is also a friend of mine. Ben, if you're listening, we got you covered. Ben is the person who taught me that, there's a saying in amongst our community, this is not your grandfather's weed, and Ben is the person who taught me, we're not talking about cannabis anymore. We're talking about THC delivery systems. Big difference. There's a big difference between cannabis and THC. And I won't get into the chemistry because our time is limited. It's not my area of expertise, but THC is the most potent ingredient of the 400 various, ingredients in cannabis. And if we're seeing the vaping or what is being called waxing of THC and getting that really high concentration delivery, I am not one of those people who is a, reefer madness teetotaler. Oh my God, cannabis is going to be the end of us. But again, we're not talking about a joint anymore. We're talking about incredibly high concentration THC, which presents significantly greater risks to the consumer.
Absolutely. Yeah. So I guess given this, and this is, there's so much here that we're obviously not addressing, and this is all very very cursory. But what it points to is, the idea that the treatment world is complex. The business of delivering treatment, continues to evolve. It is impacted by financial pressures that are shaping it in various ways. It may or may not, make it more challenging to find the types of highly specialized, individualized care and the extensiveness of care that is effective for many people and that achieves outcomes that that are long-term, holistic, whole life outcomes, that we look for. We also know that the need is incredibly intense and it's complex. And now, we kind of get to this idea of Samhsa, which is certainly, a lead organization within health and human services, is having some of its funding cut. And I guess the question is, why do we think that is, and what do we think might be behind that?
Well, I live in Washington, and cuts are, we're nothing special. It's left and right, both HHS and elsewhere. It's the name of the game right now. Within HHS, CDC, NIH, Samhsa. So I guess we're not anything special. But Samhsa is the agency I work closest with in my policy work. And policymakers will say that they understand substance use disorders are a chronic disease. It requires a lifetime of maintenance. You can call that recovery. You can call that health. You can call it whatever you want. But it is a chronic disease defined as such by the American Medical Association and has been for 70-something years, that requires a lifetime of care. However, that's not how Congress and policymakers in Washington think. They want answers. They want to show they achieve something. Quick results. Look, I fixed this problem. The best way I could sum it up is I was part of the effort 20 years ago. There was an effort to double the NIH budget. And once it was completed in a 5-year term, you could kind of tell the mood of Congress was, hey, we doubled your budget. Where's the cure to cancer? Where is it? What have you done? That's not how it works. But that's their attitude. And they want very fast results for a disorder that just doesn't yield them. Forget the fact that the average consumer has to go through treatment. I think the latest data I saw was 7 times at least. And that's if it's good, if it's legitimate, good treatment. I just think Samhsa is caught up in the whirlwind that is tearing through Washington right now. One thing I would like to point out is I am very curious how the current administration would like to explain balancing the fact that just last week they extended the public health emergency on opioids and at the same time are seeing fit to potentially cut Samhsa's workforce in half. as I said to someone recently, logic has never reigned in Washington, but it's especially out of style right now.
Yeah.
So I was kind of hoping against hope with my fingers crossed that this is one of the very few bipartisan issues within HHS that maybe we could fly under the radar and make it through either unscathed or less scathed. CDC, I know, has become partisan because of the fights over COVID, because of the research they do on gun violence. I get that. NIH has become partisan because of the research they may do that this administration doesn't like on diverse populations or gender health. I get that. Samhsa is as close as Samhsa and the work they do is as close to you as you get to bipartisan agreement in healthcare in Washington. And yet it's still falling prey to this,
Cuts.
to the cuts. Right. So I wouldn't take it personally, but I would say, does it make a whole lot of sense? Absolutely not.
And I just want to add one small thing is that, budget cuts, they're framed as fiscal discipline. And so we understand that. But targeting Samhsa suggests to me that behavioral health is undervalued. And so I believe that shows a statement. But I do also see that they are essentially cutting, at least reducing almost every single department, if that's correct, Andrew, that you're seeing in DC. I mean, there's very few that are going unscathed.
Yeah, absolutely. And it's when it comes to an agency like Samhsa, we hear all kinds of rumors. Kris, what you saw reported, what we also reported in the New York Times about these potential 50% cuts. Nothing official has come down, even though we're all hearing it and we're all pretty well plugged in because that's what we do. Something is going to happen. Yes, something's, what that may look like, I don't know. But it just shows a real lack of, what's important and what is, in agreement in terms of policymakers. And I'll say this. There's a difference between an issue being bipartisan and an agency having bipartisan support. The issue of substance use disorders and mental health certainly has bipartisan support on Capitol Hill. I'll be completely honest. If you were to go to Capitol Hill to Republicans who have said, or even Democrats who have said, I support SUD prevention, treatment, and recovery, and you say, okay, let's talk about Samhsa, their knowledge is going to be limited because they've got a lot of government to cover, So you don't make the assumption that everyone knows everything, whether it be about Samhsa or the CDC or the NIH. They've got a lot on their plates, even in the best of times and the most efficient of times. So it's really incumbent on people like us to say, I just want to bring to your attention, once again, I know we've been through the song and dance before, but I want to bring to your attention the important work that is done by this agency and see if we can, do what we can to mitigate the damage. I will say this, just every day it's a new rumor.
Okay. Because I want to ask, you have a very unique perspective, Andrew, as an individual who, interacts with our leadership and policymakers. What is it like on the ground in terms of, there are behavioral health wonks, if you will, that, maybe it's folks like us or you. But I think, what is the level of understanding and how much does it vary? Is there
a level of understanding amongst policymakers?
Yeah.
Oh, geez, it definitely varies. Like you wouldn't believe. There are those who they're not the most common, but there are those who understand the whole continuum, research and medications and recovery, There are those who understand it's important and whatever we're doing is kind of working, but they don't understand the nuts and bolts. And I would be derelict if I didn't also say there are those who think shoot first, ask question later is the right approach. Don't fool yourself into thinking there aren't members of Congress who don't think the bomb the cartel approach isn't the best idea. It really runs a gamut. And again, you'll find that on almost any issue. You'll find that when it comes to automakers, or when it comes to even just health issues like, cancer or whatever. It really does run I still find that most important role I serve for the people I work with, and you'll have to excuse my beagle who wants to be part of the podcast. The most important role I serve is not to go and say, hey, these are important programs. It's, do you understand what we're accomplishing with these programs? Okay, got it? Good. Now we can talk about their value.
Okay. Yeah. So what has already happened? Or are we seeing things that have happened as a result of, the budget cuts that have already taken place?
What has already happened is the interesting timing. What we have are truth and rumors. And almost 90% of what I'm dealing with right now is rumors. What we have is, yes, 95, about 10% of the staff at Samhsa was dismissed in the probationary employee purge. That was government-wide, HHS-wide, fine. Then we start to hear rumors of other reduction in force, possibly 50%, possibly 70%. One rumor I had was that they're coming today. For what it's worth, I've heard they're coming this week for the last 6 weeks. What we have in reality, and this is a good place to start because it's tangible, it's hard. The Trump administration yesterday made official that they are going to what we call claw back, and it's exactly what it sounds like, all unspent funds that were distributed for the COVID emergency. Their philosophy is the COVID emergency is over. These funds no longer need to be spent. On paper, and logically, again, here we go with the logic, that tends to make sense. Would I feel safer as an American if we still had more respirators, more COVID tests, more education? Yeah, but dealing in policy, dealing in facts, okay. Point given. About $11 billion is at CDC unspent that they want back. Now at Samhsa, that's about $1 billion that's unspent that has either gone out to the states or is ready to go out to the states. And when they say, quote, unspent, it is very unclear because, I'm sorry, it just wasn't clear. I'm not only an attorney, it's just the kind of person I am. I like very specific instructions when I'm told to comply with something. Is this money that has not gone out to the states that's still sitting in Samhsa accounts that they say give it back? I don't know. Is it money that's gone out to the states that the states have sitting in their accounts that they haven't spent? I don't know. It's called unobligated funds. And the question is, when are the funds obligated? When they go out Samhsa's door? When they go out the door of the states to the... However you cut it. The Trump administration has said, Samhsa, you've got somewhere between $1 and $1.3 billion of unspent COVID emergency funds. We want it back. Now, here's the problem and the difference between Samhsa and the CDC. If you are saying, okay, CDC, the CDC deals in actual COVID. And if your philosophy is to the CDC, the emergency's over, Biden declared it over, then you don't need these emergency funds. Okay. At Samhsa, when we deal with behavioral health, we saw an incredible spike in overdoses, drug use, alcoholism. Oh my God, the alcoholism spike during the COVID pandemic was unbelievable. And I don't have time to pull up my charts and graphs. I don't know if this software would support it, but I would love to direct you to maybe some resource that I can develop that shows the spike in alcohol use and isolation, depression, distress, whatever. Those conditions that evolved among the population during COVID are still very much with us today. And people who suffer from these conditions still suffer from them today. Mm-hmm. We need to help these people. And just because the emergency is over doesn't mean that the mental health and substance use emergencies that came about and spiked as a result are over. So we're in a really different boat. when it comes to, is there still need for this money? If you want to say we don't need any more respirators or any more COVID test kits or any more masks because the emergency is over, you can make that point. You cannot say everyone who developed behavioral health disorders as a result of the pandemic is fine. It just can't be done. So that is something that is tangible, that is actually consumed all my entire day yesterday. And as soon as I hang up with you, will consume the rest of my day too.
Okay. So that's actually happening. How about Nikki? What are you seeing?
Yeah. So right now, I found two examples of things that are being disrupted. And so I found an article that in the New York Times yesterday that was saying there's a Chicago Recovery Community Coalition, and they have their operations have been significantly disrupted because no calls are going answered that they're making. And so it's as we continue to do the work without any updates. And so this is not a not trying to be disparaging towards Samhsa. This is just one of the examples that they're saying because they're not able to get answers for the funding that they rely on. And so I am hearing that. I do some consulting for a nonprofit treatment center too, and they've been very concerned because they have two Samhsa grants that operate their youth prevention groups that they rely heavily on. And the questions that they have just aren't being able to be answered right now. And Kris, it's because they don't have the answers. And so there is definitely significant disruption in operations for particularly nonprofits that heavily rely on those grants.
Absolutely. Yeah.
Hey, Kris, one other point I want to make on that is the one thing that has most of us really nervous about this is what the money that went to the 988 hotline during the emergency. 988 is the National Suicide Prevention 3-digit hotline, which I put a lot of work into to see it developed along with many colleagues in both SUD and mental health. And it was a real victory for us. And I don't know, 80, 100 million somewhere, I have the number somewhere, was given to 988 in the COVID emergency package. So there's two things. One, it's not like money went out from Samhsa to the state saying, this is money for people who have COVID or are suffering from depression or SUD as a result of COVID, go help them. What really happened were existing grants were plussed up. So for example, the Substance Use Prevention Treatment Recovery Block Grant got an extra $1.5 billion to be spent down until it was spent down. 988 got an extra $80, $100 million, whatever, to be spent when it was spent. I think there was, in the second plan, a deadline was eventually put in place of September 30th, 2025. So at the very least, the statute says you have until September 2025 to spend this money. So states were planning that. Now they're saying there still might be grants going out the door. There might be applications still coming in the door to get this money out. And the White House has said, all money back.
Wow. So this is part of that clawback that you mentioned.
This is part of that clawback. Yeah. My point about 988 is just an example because this is across the board, but 988. Here's my point about 988. Whatever money is still in that account from the COVID emergency, suicide prevention is still a top priority in public health, or at least it should be. Suicide is still a tremendous problem in this country. And as an SUD expert, I will tell you, suicide by overdose, not an uncommon thing. When we read about overdoses, they usually don't break down what was accidental and what was suicide. It's not, don't assume every overdose was accidental, because it wasn't. But coroners have different rules around the country, and most say if there's no note, I can't rule it a suicide.
Mm-hmm. Mm-hmm.
Suicide prevention in the SUD community is incredibly important, especially for people who are at a point where they're using and see no way out and they want to call 988 and whatever. Let's say, for example, there's still 20 million sitting in that account that could be spent. For the love of everything holy, can you leave it there, please? What's $20 million to help people who call 988? Really? You want that money back? I mean, so 99%, Nikki knows me very well, and 99% of what I say in a policy setting is cold, hard fact. Cold, hard fact. I will never go in and make a policy argument and say, this is what I feel, because that's not how it works. These programs work. Here's why. It saves time, money, resources, lives, whatever you want to do. But that 1% of me is on full display right now. You really want money back that's going to help people who call 988 to save their lives, and you say, sorry, COVID emergency is over. I don't care if it's $1. Yeah. You want that money back?
Right.
That is where I cross from let's look at the policy and what we can do over into real anger at a policy such as this.
Let me ask you, and we could, I'm sure, talk about this for days, or more. I just wanted to kind of bring it into the conversation, if we could, a little bit. And it is the overall philosophy, if you will, of behavioral health. We've touched on this, but we have the Director of Health and Human Services today who has espoused, a particular view, of behavioral health conditions and its treatment. We've heard of, concepts like health farms, for example, and other types of things. Is there reason to be aware? I don't want to say, necessarily concerned, but I mean, there is the current evidence base, seems to point to, the fact that today's addiction treatment, when practiced extremely well, is working. Evidence-based approaches, the use of medications, the use of psychiatric medications, et cetera, to control symptoms, and a whole variety of other, science-based approaches. Does that seem to be different, now? Is there a different way of thinking about this at the highest levels? And from a practical standpoint, does what leadership believe filter down? Does it impact, ground level, approaches within government?
Absolutely. And absolutely it does. And so we have some political figures who are, the one that you just mentioned, that are leaning into non-medical wellness narratives. And part of the importance of groups like Samhsa and ASAM is that they have this research, evidence-based practices with outcomes data. And what I think that you would struggle to find is what the outcomes of these working farms, just for example. I don't know how much data that they're collecting on that is going to be. And so I think when you have someone in a new leadership role who is talking about these grandiose ideas, but without the data, which is so important, as Andrew said before, they are well intentioned, but what we're doing is we're ignoring decades of this scientific research that we've had that's showing that the disease of addiction is complex. It has a huge impact on our brain, and that opioids are, this is, so the secretary, I believe, got sober several years ago, and things are vastly different now, the way that opioids impact our brain. And so I think that that's something that needs to be taken a look at too, and that happens with science. Now, I do want to say this though too, that there most certainly can be a healthy blend. Recovery has all different paths, but we need to be sure is that we are looking at the outcomes, that we're using the science to make sure that we're making the best, safest decision for the individual. And so I think that needs to be looked at as all different types and not just one. And so I do think, but that absolutely stems down from leadership, because if you have someone who's vastly averse to using science, it's going to be hard to advocate for before your evidence-based, treatment center or your nonprofit or the resources that you're wanting to put out. And let me add this too, in regards to the resources, we talked about things that are being cut a little bit ago from Samhsa. They provide a tremendous amount of resources, Kris, to rural communities, to those underserved that are not readily available. And so that's a significant consequence of cutting Samhsa, is being able to have this safe information provided out to communities that desperately need them. So that was a long answer to a short question, which is leadership absolutely makes an impact on what the decisions are going to be.
Yeah, to me, I mean, there's a saying, I'm, you know, in the recovery community or in the treatment community, there's a saying, no wrong door, you know. And as Nikki said, and as you know, it's complex, different models for different people. What I need to see from the secretary is acceptance that there are multiple pathways. You know, there was controversy over, you know, where does, you know, I remember during his confirmation hearings, I would get calls, you know, is he opposed to medications like methadone, buprenorphine, Suboxone, things like that? Does he think these work farms or, you know, therapeutic communities, you know, are the only answer? That's where I just want him to know that's not the only way. As Nikki said, we've really evolved in terms of treatment. And, you know, from the days of the big book to, and 12-step to medications, me personally, and the people I represent, if you find a way that works for you, you do it. And if you find your community and your people, and if it's medications, if it's 12-step, if it's non-12-step recovery, if it's inpatient, if it's outpatient, you do your thing, just so long as you're not getting taken advantage of, obviously. You know, I really want to see respect for the multiple pathways. You mentioned Kennedy, and we talk about the narrative. You know, you mentioned in your introduction the narrative on Capitol Hill. What I found to be a microcosm of one of our biggest challenges in policy, and we continue to face, came up in Mr. Kennedy's confirmation hearing, and he was talking about addiction. And again, it was only a small part of his, because again, HHS is rather large. But when we got to the part about SUD treatment, he made a comment about methadone being helpful and how it's necessary to, quote, I'm paraphrasing, but I think this is pretty close, get people off the streets. It's a good tool for that. And it stuck out for me because it plays into this trope that there's only one kind of person who needs help, and that's the person who's homeless in the gutter. And that's not the case. Addiction touches every corner of society. There are people who live in the finest houses. There are people who live in condos and apartments and wherever you may be who struggle with substance use disorders. It's not just, you know, and so that kind of, maybe I'm extrapolating too much from one comment, but it kind of hit a mark for me because that's the example he chose. And what that illustrated was, oh, this is a disease of the downtrodden, of, you know, I guess the lepers, you know, in the 17th century, the people you don't want, you know, who cause all the NIMBY problems. I never approached that this way because I was taught when I entered this field, all shapes, all sizes, all kinds, no matter where. And those of us, you know, who have seen SUD impact our family and friends, which is everybody, because I've never met a person who doesn't have a family member. You know, we've seen that people can live in the nicest houses and have the best jobs and make a lot of money and still struggle. So if I had two wishes for the secretary, it's don't get fixated on any one approach and don't get fixated on any one type of person. And that's the same. And I mentioned chronic disease before. You know, the chronic disease we usually turn to most when wanting to make a comparison is diabetes. Does every diabetic have the same plan? No. Are the elements the same? Diet, metformin, insulin in different doses. You all hit the same points, but your plan is your plan with your doctor. You may bring this drug up and this drug down. You may bring this in your diet up or down. You may bring your exercise. You've got to find what works for you with your healthcare team. And in that regard, that's the most important thing we need from this administration is respect for that approach.
Thank you. Maybe just to close this out and to respect our time, we could talk about this. I could certainly listen to you talk about this forever, for sure. What should we be watching out for? So we, as say the behavioral health treatment field, these are uncertain days. We just talked about this. There's a tremendous amount of change. There's a change in thinking. There's a change in funding. There's a change in everything. What should we be on watch for, if anything, or what should we be looking out for that we might want to be concerned about?
Well, as I've said, it's like, when does rumor become truth? And when it becomes truth, is it too late by then? I don't know. Me personally, because I work in policy and I'm a budget wonk, the one thing I'm looking forward to most is the president's FY26 budget. All of the potential changes you hear about potentially happening, and they range from changes in organization at HHS. Will there be a Samhsa? Will Samhsa and HRSA and CDC become one? Will CDC be split up? Will Samhsa be split up? Will HRSA be split up? All these things that are laid out, and all of the budget cuts that could be coming, I think a lot of questions will be answered in the FY26 document, which kind of goes hand in hand with what the current majority is trying to do with their reconciliation, which is going to be a much slower progress. And again, if you want a 6-hour podcast, have me on to talk about reconciliation.
100%. Absolutely.
That's what I'm looking forward to, because that's when it's real.
When does that come out, Andrew? When do we see the budget? When do we see the budget?
In the best of times, in an incumbent presidency, you usually see it end of February, early March. In a transitional year, usually you get a skinny budget in April and the fuller thing by like a month, 6 weeks later. Now, because they've been so busy doing what they're doing and so busy with reconciliation, we're expecting some kind of document in May. And I'm not expecting the most detailed document, but I am expecting some very broad strokes with what does the future hold for the organization of HHS? And that's when we can go to Congress and say, this is not acceptable or this is a good idea. Now, there's a saying, president proposes, Congress disposes. That's not necessarily true, because the president's budget is a flag in the sand. It's a marker, and it's the members of Congress want to know, what did the president's budget recommend? If it was an irrelevant document, they wouldn't ask that, especially members of the president's party. So, short answer, I'm looking for that budget sometime in the next, I'd say about the last week of April, I'll start to look for it. Between now and then, I can only take what comes, like that announcement yesterday about the clawbacks. Nikki?
Yeah, so two things on that of what can we look for, what can we do. And I was in Annapolis in the Capitol on Thursday, and one of the state senators said to me that everything that comes out, they wait 3 days to do anything. And I think that was really good advice, because instead of having this whiplash effect, which started happening at the beginning for one of the nonprofits that I work with, there was an announcement made. Trump had put something out on Truth, or whatever platform he uses, and everyone got all in a panic, and then it was swiftly changed the next day. And so I think waiting 3 days right now is good advice for when something is said or something is put out there to what is actually going to happen. So I think that's one thing to do. The other thing, another nonprofit that I work closely with, it's business as usual, but you're going to have to do some outside of the box thinking. So the way that you can no longer rely particularly on any federal type of sources that you used to get for income right now. You're going to have to be creative, think outside of the box, and be willing to look at different revenue streams, because there's no guarantee anymore.
Wow. Well, that has, obviously real impacts, not only on these providers and but on people, and patients everywhere. It's a hugely important conversation, and there's a lot to it. And I thank you both so much for taking the time to talk about it, today. It's very interesting. It's absolutely vital, and I think we have to watch this space really, really closely.
Too. There's one kind of last part that wanted to infuse is that for the listeners that may not be familiar with Samhsa, because it may not be a household name to some, but those in the field most certainly are familiar. It really is the backbone of how a lot of federal dollars get into those communities, and specifically to nonprofits too, to address the behavioral health crisis. And if you defund Samhsa, you're cutting the vein of the system. And so I think that that's really important to remember, that if you are going to eliminate that, we're in for a whole heap of trouble.
In addition, beyond that, one of the former directors of Samhsa, my friend Charles Curry, who was director under George W. Bush, said the highest value of Samhsa to him was the seat at the table. When the HHS secretary gathers everybody and you have the CDC and HRSA, and if Samhsa wasn't at the table, behavioral health wouldn't come up. Yeah, HRSA's got some grants, CDC's got some grants, NIH has some grants, but they also have to deal with cancer, HIV, diabetes, right, everything. And unfortunately, we still live in a day and age where with behavioral health, they get to it when they get to it. With Samhsa sitting at that table, they're saying, guys, don't forget. And so even every bit as important as the dollars is that seat at the table that's saying, the saying that the mental health community has, no health without mental health. You could say no health without behavioral health. But one of the largest public health problems we have in the United States should have its seat at the table. And Absolutely. That's why we need a strong Samhsa.
Definitely. And promise this is the last thing. One of Andrew and I's friends, Tom Cordair, is, I feel like he deserves a really special shout out for all of the work that he's been doing there at Samhsa. You want to talk about a voice of reason at the table, Kris? He is most certainly one too, who's been working really diligently there. So there's some really good people
Tom Cordair is the acting director at Samhsa during this transition, and he's working his tail off. He's a dear friend to both Nikki and I and everyone in the recovery community. Like, if you're in this community, Tom is your friend. And I just hope he's holding it together, because like everyone in his position across government, it's some tough times. But Tom's tough. So
yeah, that's good. Well, it also underscores the huge importance of the work that you both do, and we thank you very, very much for it. And so I think that's the time that we have for today. And I know we're just touching on some of these topics, but it really has been tremendously enlightening. And thank you both so much for making the time to talk about this very, very important issue.